This is a continuation of our last class when we were talking about brief consultation structure. We'll be reviewing the sections on assessment and bridge to intervention, as well as some considerations for intervention and follow-up. So when we talked last about the structure of an initial appointment, we had practiced the introduction and bridge to assessment, which, as you recall, was an open question focusing the conversation around the referral question. And in our assessment, we briefly discussed that there were three important components that we wanted to try to get to. The first being a diagnostic scan for the most likely disorders. The next being daily functioning, where we want to assess how somebody is coping in work, with family, in social settings, and in leisure pursuits. We also want to have a sense of how they're coping in the present, as well as in the past, to manage their symptoms. So that ordinarily can take 10 to 15 minutes. It's very helpful if you have a list of diagnostic criteria for a couple likely disorders, and in the upcoming practice you'll have access to a list of the criteria for a major depressive episode, and you'll have the opportunity to practice assessing for depression in the vignette. Following the assessment, we have a bridge to intervention, which can last anywhere from 30 seconds to maybe a minute or two. In this section, we want to summarize the findings of your assessment using objective language, and really again clarifying through reflection what the primary focus of the consultation is, whether it's a depressive episode, relationship problems, managing medication, or chronic illness care. And after the summary, we also, or as part of the summary, want to highlight instances of successful coping or reduced symptoms. And this can often lead to an increased sense of hope for the client. What has worked for you? And we mentioned the question, what were things like for you in your life before you started to feel more depressed and started to have less functional mobility with let's say the chronic pain that you were experiencing. We also, in this bridge, we want to end the bridge with an open question to elicit ideas about what the patient's next steps might be. A nice open question that can serve as a bridge to intervention would be, what have you thought about doing about this, considering how you've been coping with it, both now and before? Where does this leave you? If there were three options you could put on the table for what to do next, what would those options be? And we want to strive to offer our patients as many options as possible, or elicit as many options as possible first before offering them from our perspective. But either way, not just putting one maybe homework assignment on the table. So now this is a time where you have an opportunity to practice an assessment and bridge with somebody, either a peer or a friend or a family member, since we're not in class. And the vignette basically is a rough sketch of a patient who MH had a heart attack 6 months ago, has been struggling with being overweight, has also been feeling down since they lost their job as a bookkeeper for a small business. what we want to do is assess for a major depressive episode with the DSM criteria, which I'll put up on the screen next. Again, we want to keep in mind, along with just whether they meet the criteria for a major depressive episode, how they have been coping in the past and present, and what, if any, times that they've experienced where the depression has not been as strong. We also want to, if we can in this assessment, is get a brief read on their readiness to change diet and exercise behavior. And if you recall from last class, an excellent way to do this is using the importance and confidence rulers from motivational interviewing, and remembering that the first question we want to ask in the scaling questions is not only after what number they rate themselves, but what makes them that number and not a couple points lower. Before we ask the question, what would have to happen to move you up 2 points in importance or confidence, depending on which ruler you're using. In terms of our diagnostic scan, we want to ask permission to enter a more directive mode with clients and signal that this will involve a series of closed questions. And you can form those closed questions based on the 9 symptoms of depression. You'll have this sheet in your email as a sheet that you can refer to during your practice. Following the bridge to assessment, we move into intervention, and this can be any. Following the bridge to assessment, we move into intervention, and this can be anywhere from 10 to 12 minutes, and there's certain features of an intervention and brief consultation in medical settings that we want to pay attention to. The first is that we want our intervention to be concrete, practical, and aimed at symptom reduction or improved functioning. So if your assessment has come up with a likely diagnosis of panic disorder, an intervention may be teaching diaphragmatic breathing in the first session. It may also include psychoeducation around panic disorder and the panic cycle, what a panic attack is, and education around the idea that anxiety isn't dangerous. Another example of a concrete and practical intervention is orienting somebody to a thought record, showing the first 3 columns of a thought record where somebody's you're doing this with them, helping them identify negative automatic thoughts, the situation that's associated with those thoughts, as well as the feelings that are attendant to the situation and the thoughts, and having them rate the intensity. I often find for a first session that that going through a whole dysfunctional thought record for many clients is too much, and that the first 3 columns is a nice gradual way of orienting them to the importance of monitoring their thoughts and understanding them as contributing to symptoms. We want our interventions to be supported by the primary care provider and easy to reinforce. And at the end, toward the end of the intervention, it may result in a plan for practicing whatever the skill you've worked with the client on in between sessions. And we want that practice, we can call it homework, personal growth activities, to be reasonable, achievable, specific, and time-framed. And this is really tied in with helping the healthcare team to reinforce the assignment if it has those elements. So for instance, for somebody who is suffering from major depression, perhaps you provide some psychoeducation around the importance of increasing the frequency and intensity and duration of pleasurable events, and you may schedule 1 or 2 pleasant events with the client, and exploring when it might be the easiest for them to accomplish those activities, and attending to maybe a couple dimensions that we've found important in behavioral activation for depression, which is mastery and pleasure. So rating those on a scale of 0 to 10 may be helpful for the patient to understand the value and be aware of the value of scheduling those events. We want to be careful not to overwhelm or overload patients with intersession activities, or even with the intervention. We don't want that to be too complex or involved or beyond what the patient is ready for in that initial session. So we're doing some metacognitive assessment of their readiness and the receptivity to the intervention prior to implementing it. The next phase is feedback and follow-up of the consultation. So once you have completed your assessment, you have a likely diagnosis, the patient has collaborated with you in generating some possible steps toward reducing symptoms. The intervention that you've implemented is practical, concrete, reinforceable by the primary care provider. You want to move into a brief feedback and follow-up. So we always want to elicit from patients what was helpful or unhelpful about the session. What question I like is, what can I do better to make this time more effective for you? Or what can we do better here? We also want to agree on a time to come back, and maybe even a preview of the format of the following sessions. So saying something like, after today, we may meet 1 or 2 more times, and where we'll start out with just a quick review of how your between session activities went, what your mood's been like, how you've been coping with your physical and your emotional symptoms, and then kind of moving into what it is you want to talk about for that, or focus on for that session, and then maybe some practice or skills training. And so it's helpful to provide that framework ahead of time so that there's some familiarity or understanding of what that experience will be like, and it may help you increase the likelihood of engaging patients. So there are a couple common pitfalls for the intervention in brief exam room contexts that we want to be aware of. So usually in a 50-minute session, you may have more time to provide a more full rationale or background on a given disorder, be it panic disorder, depression, or an anxiety disorder. And so handouts in those in that format can be briefer. But when we only have a little bit of time, we want to make sure that our handouts are a little bit more comprehensive. We don't want to limit interventions only to those that we have handouts for. So even if you don't have a handout on diaphragmatic breathing, that shouldn't prevent you from teaching diaphragmatic breathing. We also don't want to be too conservative about who will be seen. So if we suspect that interventions in CBT interventions in a medical setting and a brief consultation model are a mismatch for a client's clinical presentation, maybe they are experiencing a personality disorder on top of psychosis and with multiple layers of psychosocial stressors, and we feel that specialty mental health would be a better venue, an avenue of treatment for that particular patient. We don't want to reject referrals that come from the primary care provider for those types of presentations. We want to welcome those and then help facilitate linking that individual to more appropriate services. Another common pitfall relates to follow-up, and oftentimes when working as a counselor in medical settings, we're working kind of in the familiar model of specialty mental health, where appointments are a week apart and 50 minutes long. Oftentimes there's too brief an interval between the initial visit and the follow-up based on that schema of therapy. In medical settings, it often doesn't afford patients enough time to practice or benefit from the interventions. So we want to keep that in mind. Let's say you're planning or collaboratively you're planning with them to increase the number of pleasant events that they're going to try to schedule or engage in. So you might want to do that across 2 or 3 weeks if you know that your follow-up is going to be maybe 3 weeks from now or a month from now. Back-to-back sessions, or sessions separated by a week or a few days, one of the effects that can have, it can limit the sense of responsibility for patients. One of the principles of patient-centered medical homes is encouraging the self-management of chronic conditions, and the more we can help patients feel empowered and taking charge of their own care, we're attending more to that model, and also reducing the likelihood that they're going to develop a sense of dependence on the behavioral health consultant, as seeing them as the person who can fix their problems rather than somebody who is assisting them in developing a greater sense of self-efficacy and control. If, again, too brief of an interval between your initial visit and the follow-up, from a practical PCMH standpoint, it reduces appointment availability for the broad population of patients that need behavioral health services. So we very much want to remember about PCMH is that we have a population health focus. The other common pitfall with follow-ups is always scheduling a follow-up. There may be patients that you see who just require one session to learn a single skill, or perhaps they're functioning fairly okay, and helping them increase an activity in their life or work on a communication skill will be the one intervention which is helpful for them to achieve even a greater sense of control and sense of well-being, which is sufficient. So we shouldn't automatically assume that every person will need a follow-up. So now we're going to switch modes to talking a little bit about culturally sensitive health behavior change interventions. This follows on the heels of using motivational interviewing in that 3-step model from last week, what we've been talking about as far as the model of elicit, provide, elicit, as a way of always, a spirit of always wanting to understand the patient's perspective before we offer our own or assume that our own expertise is a good fit. And I think that has built in with it a culturally sensitive core. And there have been some other health behavior change interventions which have been culturally modified so that they're sensitive and responsive. And we want to remember, too, that in Section A of the ACA Code of Ethics, it reminds us that counselors actively attempt to understand the diverse cultural backgrounds of the clients we serve, while self-reflecting on our own personal values and cultural identities. So that is it's a prime directive, ethical directive that we have, and not only through the relationship, not only interpersonally, do we want to use our reflective listening skills and the elicit, provide, elicit type of approach, but we want our interventions also to reflect cultural understandings. And the reason is that it will, one of the prime reasons is that it's going to increase the effectiveness of the intervention if there's a good match with somebody's cultural, religious identity. One of the readings for last week looked at a modified smoking cessation intervention that was shaped for Asian immigrants with serious mental illness. And this was an intervention that used cognitive behavior therapy, motivational interviewing, and nicotine replacement therapy. It was a combined individual therapy with a group modality. The group program was offered in several languages. When we take a look at what are some of these culturally sensitive modifications, and we see that alternative behavioral strategies for coping with nicotine cravings, meditation, and prayer. They also used more of experiential and tactile learning. So instead of offering a worksheet which maybe describes the risks of smoking, they would take participants in the program to on field trips to stores where they not only saw the price of cigarettes, but in addition to that, offering them exposure to clay models of healthy and unhealthy lungs. So very much an experiential approach was more effective with this population. Female Cambodian clients showed, and so we see some different gender norms for smoking, which this intervention, the smoking cessation intervention, was sensitive to. For the female Cambodian clients, there's considerable variability in attitudes towards smoking, so some viewed it as liberating, while others viewed it as shameful. Women tend to chew tobacco more than they smoke, and we see in the Cambodian culture that chewing is a rite of passage into womanhood. For men, there was a little bit less variability in attitudes towards smoking, and that men considered it more of a favored pastime. We also saw, as far as a culturally sensitive modification, the use of the therapeutic relationship and family relationships to increase participants' motivation to stop smoking or even participate in the program. So, for example, and this is something that's interesting in light of our Elicit, Provide, Elicit and the spirit of motivational interviewing, that may come across at first with our Western values as coercive, that a clinician said to a participant that it would save face for him if he would join in the intervention, if he would participate. However, for that client, saving face was a custom that was very much understood and welcomed and honored. Another intervention was involving values, and specifically family values, into motivation for smoking cessation. One particular participant had a daughter he was estranged from, and this daughter was only really interested in reconnecting with him if he stopped smoking. And so the therapist used this dilemma as a reason for change. And when I say used it as a reason for change, I'm saying that perspective from an MI perspective, that reason for change was elicited and brought into greater focus and awareness for that client. And we saw one of the most poignant changes that we see for this program versus other smoking cessation programs with white majority culture populations, is that this program was moved from a standalone to an integrated program in a broader wellness context. So that was more culturally acceptable for the population. We also see a rise in the evidence for using church-based health promotion interventions. And there's a number of reasons why that's becoming more advantageous and is more effective. We see, for one, a rise in megachurches across the United States. 85% of Americans identify with religion. Additionally, church-based health promotion interventions help reduce disparities among African American and historical Bible Belt communities. In addition, we see a consonance of understanding between healthy lifestyle choices and religious beliefs. That includes vegetarianism by Seventh-day Adventists, and in many religions, the prohibitions for eating pork, drinking, and smoking. In addition, one of the advantages these interventions offers is access to groups that are already convening regularly. So there's typically strong social networks and support built into churches. And along with that, the resources to conduct health promotion have been increasing over the years with greater federal funding for health promotion projects. Churches tend to be more stable than work settings, and these types of programs may reach people who traditionally wouldn't participate in a primary care-based health intervention. So it enhances a sense of trust between the interventionists and the participants. And in addition, the Black church has often stood at the center of spiritual, social, and political life for their communities. and it really enhances the legitimacy of public health initiatives as well, in addition to fostering greater trust. Health behavior change is more enduring when intervention occurs at multiple levels of influence. And we can apply the socio-ecological model and understanding the levels of change and the targets to church-based health promotion programs. At the intrapersonal level, we've talked about motivational interviewing and the influence of changes in individual knowledge, attitudes, beliefs, feelings regarding past experience. MI can be delivered both individually at the interpersonal level, have effects, but in addition can have effects at the interpersonal level. And in addition to MI, at the interpersonal level, we see the targets of social support, family, friends, church members, and in church-based health promotion programs, oftentimes lay health advisors, when those programs are delivered by those advisors, people are more likely to obtain colorectal screenings and engage in other healthy behaviors. Church-based health promotion interventions have an organizational reach as well, and this can sustain motivation, respect, credibility, social meaning, leadership. If you have a pastor who is actively promoting the intervention, you have the church sponsoring activities related to healthy lifestyles like fairs, health fairs, policy changes at the system-wide level involve serving healthy foods, dissemination of healthy lifestyle information through church bulletins. And finally, at the environmental policy level, we have media advocacy and federal funding as all supporting healthy options by influencing the infrastructure surrounding the church. So again, when we can see an intervention that touches on each of these levels, that's woven through the intrapersonal, interpersonal, organizational, environmental levels, we can expect that change to be more enduring. When we look to the research and evidence supporting these programs, most studies have involved church members in the implementation, not only in the implementation though, but within the research design. So we call that community-based participatory research, where the community representatives help select the measures, determine how an intervention will be implemented, may modify those interventions to be sensitive to their specific communities, and that type of involvement in and of itself, from the ground up of a research design, is essential to developing partnership and building trust. These studies have shown significant effects of church-based programs on nutrition, exercise, as I mentioned before, screenings, smoking cessation. We do need higher quality studies, as many of these studies often don't have a control or a comparison group. We see that, in most of the health promotion literature, the samples typically are white samples, and this evidence helps. These studies help balance out the overrepresentation of white populations by studying African American populations. So we, as a whole, I think we need to study these programs further, and increasingly work as counselors as part of church-based programs when we have the opportunities to do so, because I think there's a healthy sense of skepticism and suspicion of people who are researchers, counselors, therapists outside of the church communities, which may affect building rapport and ultimately the effectiveness of the intervention. Culturally responsive interventions are one key manifestation of ethical practice. Now we're going to turn to the wider range of ethical issues and decision-making approaches which are unique to medical settings. I'd like you to consider this scenario. It's a busy day at a primary care clinic, and Sam comes in. He's a 42-year-old African American. He works odd jobs in construction, has a history of type 2 diabetes and coronary artery disease. He was described by his PCP that day as demanding, argumentative, non-compliant, and draining. This taking place in a hallway consult. His PCP prescribed him Zoloft for depression about a month ago, and now Sam is reporting some racing thoughts. You find out through your hallway consultation with his PCP that first of all, it's clear the PCP's level of frustration with Sam, saying that I wish he would leave the practice if he won't cooperate. You find out as well that Sam recently lost his job insurance, and that his home is currently in foreclosure. You notice right away in your consult that Sam is agitated, restless, with labile mood, so laughing at one moment and then a bit tearful the next. There's evidence of some paranoia. Sam says that he feels like people are out to get him. He admits he's thinking about overdosing on his heart medication. So I'd like you to take a moment now to think about some ethical issues that might play into this scenario as a counselor, as a behavioral health consultant working with Sam. So take a few moments to write down some of the key ethical issues you'd want to be thinking about. So one issue we want to consider is the role you have as a consultant. We can look to the ACA Code of Ethics in provision D2, which talks about consultants have an obligation to develop with their consultees a clear understanding of what the problem is, what are the goals for change, and what might be some of the predicted consequences based on that particular patient's decisions. In Sam's case, we wonder a little bit about his level of cognitive organization and his the coherence of his thought processes. Would he even understand what a consultant is, or the interdisciplinary team approach that we use as consultants working in healthcare settings? There's some question that paranoid ideation may interfere with Sam's ability to comprehend who you are and just how you propose helping him. Does Sam understand the difference between a consultant and a mental health counselor? In consultation, again, the emphasis, there's a greater emphasis on self-directed, empowered change, whereas in more specialty mental health and traditional mental health services, there may be a sense that patients would have, that they're going to receive a greater intensity of support, duration of support, and complexity of support. Another ethical issue you might want to consider is informed consent and confidentiality. The American Counseling Association's Code of Ethics addresses this explicitly in Provision A2 and defines informed consent as really a part of an ongoing counseling process. It's an ongoing part of that process where we are constantly supporting a patient's freedom to choose whether to enter or remain in a therapeutic relationship. That subsumes, informed consent subsumes confidentiality, and that patients understand they have a right to confidentiality. And at the same time, we need to explain the limitations of confidentiality. So we wonder, in Sam's case, does he know that he can turn down BHC services without that having an impact on his medical care? And again, are his thought processes too disordered for him to understand what the limitations of confidentiality are? So if you need to report to somebody else of Sam's suicidal ideation, would he understand that this is not, would that feed into some paranoid ideation that he's been experiencing, and potentially lead to an escalation in his level of resistance or how upset he is. Third issue we might want to consider is advocacy. Advocacy stipulates in A6 of the ACA Code of Ethics that the counselor makes efforts to advocate for clients at the individual, group, institutional, and societal levels. And advocacy includes helping individuals overcome barriers and obstacles. They may be related to transportation, financial assistance, resources, both at the state and city level, connections potentially to support groups, and they also may involve advocating for patients as a behavioral health consultant with their physician. So we have a situation with Sam where his PCP is feeling pretty frustrated with him and may not be in quite the best place to empathize and prescribe helpful courses of action for Sam, whereas perhaps the motivation and the values for that physician at that point in time is to remove the difficulty of Sam's presence and behavior from a very busy practice and what is potentially seen as an interfering force in that day. So Sam's case calls for a sensitivity to potentially helping the physician establish a greater sense of empathy with Sam, and potentially just not knowing the full extent of Sam's stressors, and just understanding that if you're able to provide feedback on those stressors could lead to a change. And also directly, we want to think about how can we directly advocate for Sam, in this case potentially giving him resources that people may find helpful when they're at risk of homelessness. There's also an obligation to, as a counselor, to support employment. One client I worked with in the healthcare center had lost his job, and some of our work we did together was role-playing for a job interview. So maybe not something you would traditionally consider a part of therapy or consultation, but more, it seems more along the lines of career counseling. We find ourselves advocating when we attend to occupational concerns, as well as basic support concerns. One factor that's very important to remember related to advocacy is that we must always ask for the patient's consent before we engage in advocacy efforts. It can potentially be very disempowering and rapport destroying to advocate without that permission, especially if the patient does not want that or feels somehow undermined by those efforts. So we want to ask. We want to be transparent in our work as therapists and consultants. So another ethical issue we might consider is boundaries of competence, C2 in the ACA code. And that is, we practice within boundaries of competence when we are staying within the realm of our education, our training, our supervised experience, our professional credentials, experiences within diverse populations, if we have those experiences or don't have those experiences. It is incumbent upon us as consultants and counselors to pursue continuing education, to stay current on the most recent research and empirically supported interventions for different populations, and knowing, having a sense of what we don't know. And in Sam's case, we have a situation where you as a behavioral health consultant, we've sort of discussed this scenario already, understand that an antidepressant may exacerbate a manic state. So we may want to help Sam, help him be placed on a mood stabilizer, and how to do that without crossing boundaries of competence. We don't necessarily want to say, Sam, I think you should be prescribed a mood stabilizer. So thinking about how we can do that, and that leads us to the next ethical domain, and that is within the interdisciplinary relationship that you have with Sam's PCP, which again we've discussed. But just briefly to cover the key idea here within interdisciplinary relationships is that the quality of services provided to our clients often depends on the quality of the interactions that we have with the healthcare team. If you're not really getting along with Sam's PCP, the likelihood that his physician is going to assimilate new information about Sam's case and potentially develop a greater sense of empathy and be able to support Sam in new ways is severely limited if you don't have a positive working relationship with that physician. And going along with interdisciplinary relationships, the focus should always remain on how best can we serve the clients versus the system. While we do want to serve the system, it's our client's welfare, the patient's welfare that we see coming first. Leading into the next ethical issue we might want to consider, noticing that this is a busy primary care clinic, there may be an organizational pressure to get Sam out of the picture, to really minimize his impact on the workflow of the clinic. However, we have to ask ourselves, are the actions that we take, are they in Sam's best interest, while at the same time sensitive to organizational pressures? When the demands of an organization conflict with the ACA Code of Ethics, it's incumbent upon us, again, as consultants, as counselors, to specify the nature of that conflict, to be clear about what that conflict is, to express when and to whom it's appropriate to express this to, supervisors, clinic directors, that we have a commitment to the Code of Ethics, and that we work to change behavior within an organization, and we try to do so in a way that's collaborative versus confrontational. One of the challenges we face in practice is to consider all of these ethical content areas simultaneously. And so what can be helpful is applying a heuristic for guiding our thought processes when we need to make ethical decisions. And we turn to Kitchener's model just for that reason, which can increase the likelihood that we're going to make good decisions that are good both for our patients and for the healthcare system in which we function, and for the interdisciplinary team of which we're a part. The first level is, in Kitchener's model, is the intuitive level, and that basically refers to what feels right. And it's usually referred to as kind of like your gut instinct, your gut feeling, what on a nerve, or what's the reflexive answer you might come up with when you have an ethical question in front of you. But we progress from the intuitive level a bit deeper, and so we have to consider not only what feels right, but at a critical evaluative level, what are the ethical principles that apply to our decision, and are those principles in conflict or in alignment? We also, at the critical evaluative level, want to consider what are the rules, what legal obligations do we have, what codes within our ACA handbook do we need to consider. So, for instance, let me just give a couple examples of moving from an intuitive level to a critical evaluative level, and using these two processes and making a decision in a stepwise fashion. So with Sam, it may feel right to, after meeting with him for 20 minutes and discovering how much duress he's under with regard to the foreclosure on his home, the job loss, insurance loss, to leave the exam room, pick up the phone, and begin calling the Department of Mental Health Services to find homelessness prevention resources, and then come back and go over with Sam a list of those resources, give him a handout of where he can go and who he can talk to. So that's at the intuitive level. That's what that process would have us potentially do. If we, before we make that decision, move from the intuitive level to the critical evaluative level of decision making, we would have factored in the question, have we gotten Sam's consent to do this kind of advocacy work? Or the risk being, if we only operate at the intuitive level, that we're impinging on Sam's right to free decision making, controlling his course, the principle of autonomy, factoring in highly into our decision making. So we can see how both the intuitive level sets us, can often guides us in the right direction, and the critical evaluative level fine-tunes our focus in that direction. Another example within the case that we've been discussing, Sam has reported a thought of overdosing on his heart medication. So at the intuitive level, I would hope as a counselor, you would want to explore further what is the severity, duration, frequency of his suicidal thoughts. Does Sam have an intent to do this? He apparently has the means, but has he been stockpiling medication? Has Sam had prior attempts? What are some of the deterrents potentially that he has to suicide? The supportive family members or friends. Has he begun making gestures, giving away possessions? Is there a history of self-injurious behavior? So we would want to assess further, and there's an instinctual movement to do that. And again, before making that decision, before jumping into assessment, if we move from the intuitive level of decision making into the critical evaluative level, we would again consider, have we informed Sam of the limits of confidentiality prior to our suicide assessment? Because if we uncover a really imminent threat to his life, then we will have to break confidentiality, and it's important in terms of maintaining a sense of trust and supporting Sam's autonomy. And this is all assuming, for both of these examples, that we've done a cognitive assessment, and Sam is not suffering from a psychotic disorder, and he is coherent and oriented to person, place, and time. So we're making that assumption. And also, have we, prior to our suicide assessment, informed him of limits of confidentiality regarding homicidal ideation? Because if we do uncover that ideation, which is active and imminent, as we know, we have a duty to warn. So at the critical evaluative level, we think of the Tarasov case and are reminded of our obligations as a counselor.